Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our experts. Well, thank you so much for submitting your questions in advance of tonight, and the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. And if you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you'll see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Alexandra Toluca with cardiac surgery and Dr. Lee West with cardiac surgery. Well, thank you both so much for joining us tonight. I will go ahead and give each of you just a minute or two to say hello. You can provide a bit of background information about yourself, and then we'll dive into the questions. So, Dr. Toluca, we'll go ahead and start with you. How are you doing this evening? And I think you might be on mute.
There we go.
There you go.
Okay. Sorry about that. Good evening. Let's hope
No.
that we got all the kinks out.
Mhm.
Um, so yeah, no, I mean, so I'm Alexandra Toluca. I've been with, well, I guess not with, I've been at Einstein. I've been in practice for about 10 and a half years. Um, and, I do all things sort of adult cardiac surgery. I, focus mostly on valvular heart disease, aortic disease, and like what we call structural heart disease, being like percutaneous valve. So that's sort of my area of expertise. But I see all patients. We're now part of Jefferson Health, and that really expands, I think, everyone's options and patient reach. So I'm happy to be here tonight. Thank you so much.
Absolutely. And we're excited to have you. All right. Dr. West, how are you doing this evening?
Doing well. Good evening. My name is Lee West. I'm a cardiac surgeon. I mostly operate at Abington Hospital, but I also cover Torresdale, which is another Jefferson hospital, and I operate at Center City as well.
All right. Well, thank you both. Without further ado, I think we're going to go ahead and just dive into the questions. I know we have a lot to get to tonight. And thank you all for submitting your questions in advance. So let's get to it. Question number one, Dr. Toluca, this one is for you. Are there tests to best evaluate the health of your heart? And are there tools for patients to support a heart healthy lifestyle and measuring vital signs like blood pressure, heartbeat, etc.?
Wow, very broad question. I mean, I think, key sort of things here are, we'd like to focus on preventative care, if at all possible, in the cardiovascular space. I mean, heart disease is still the #1 killer in the United States, and, we have a lot of way to go. So I think keeping the primary care sort of appointments, making sure you get your physical and sort of being informed about your health, making sure that if there is family history of heart disease, you speak up, because there are different ages, different categories, and there are a lot of tests out there to get into. And it's just very important that you sort of talk about your risk factors with a cardiologist first, if there are risk factors. But yes, there are a lot of tests. As far as sort of home monitoring, I mean, I wouldn't sort of really start doing that unless talking to your physician, because you have to also know how to interpret things. I mean, I know there are a lot of, smart watches out there, applications, and sometimes it's good. Like, let's say you feel palpitations and you happen to have a smartwatch, you can try to capture it. I mean, there are a lot of there's a lot of technology available, but at the end of the day, to interpret it and know what to do with it, you should see your doctor.
All right. Well, thank you. Okay, Dr. West, we will turn to you for the next question here. Is there a secondary diagnostic heart exam after an EKG reads as normal, but someone might still have concerns?
Um, so a normal EKG just tells us basically, backing up, an EKG is a snapshot of your heart's electrical activity. And having a normal EKG just means that your heart may be in a normal rhythm at that time. So if your cardiologist or your primary care physician has concern, he might or she might put you on a device that looks at your heart rhythm over 24 or 48 hours called a Holter monitor. And then that will show us what your heart's doing over an extended period of time. So for normal EKG is done in the office, it doesn't mean that it'll be normal, in an hour later or a day later. The other thing that your cardiologist might do is something called a stress test, where they do an EKG at rest, and they put you on a treadmill, or they give you medicine that will stress your heart, and then do another EKG to look to see if there's any changes. Or based on your EKG, they might want to do other tests like a echo or something, some other imaging that looks at the actual structural functioning of the heart.
Okay, thank you. All right, moving along from testing now, Dr. Toluca, this next question. Can you discuss heart attack warnings? So when to seek care, and maybe the difference between heart attacks and stable disease? And one final question, I know I'm adding on here. What is a symptom of a clogged artery?
Okay. So we can start with that one first, because actually that sort of ties in with your first question, signs and symptoms of a heart attack, and a heart attack, or a sort of, a heart attack per se is when part of the heart muscle stops having blood flow. So like some patients say, oh, I had like a stroke or something, but really it just means that either a plaque ruptured or a clot formed, or something prevented blood flow to the heart muscle. And there could be a small amount of damage, a large amount of damage, depending on what artery, how quickly it was identified. So that's sort of the definition loosely of a heart attack. And some patients say, oh, like I had a heart attack, but my heart functions normal. Did I really have a heart attack? And it's like, yes, because based on blood tests and in the bloodstream, we identified that there was damage to the heart muscle. Thankfully, it wasn't a large amount of damage. And, based on like if the patient had a stent, or the patient had surgery, or was treated appropriately with medication, we're able to prevent that. I would say there are some classic warning signs that everybody should be aware of. So for example, crushing chest pain. Patients say, oh, I feel like there's an elephant sitting on my chest. Pain going down the arm, up the jaw, feeling clammy, feeling nauseous. Sort of all things, and they can happen very suddenly. So if those things do happen, that is a 911 call, because there could be an active heart attack or a heart attack waiting to happen. Stable disease is more what we consider, there are blockages, and the patient has what we call symptoms, meaning there are signs that there isn't enough blood flow going to the heart with activity. So let's say someone is going up the stairs carrying something heavy, and they feel a chest pressure, or they're shoveling snow. So we see this a lot in the winter. They just sort of increase in effort, increase in blood pressure, they experience chest pressure, but then when they rest, that goes away. So that is a sign that there could be heart disease, but it doesn't mean that a heart attack is actively happening. And that's when, you see your cardiologist, or you see your primary care doctor first, then they send you to your cardiologist, then they do all the workup. And like Dr. West said, I mean, it could be as simple as an EKG in the office. And if that shows something concerning, you might have to go to the emergency room. Or if the EKG shows nothing, but there is enough suspicion, you go on to a stress test, possibly directly to a heart catheterization, which means an invasive test looking at the coronary arteries. So I'd say those are the most common signs and symptoms of a heart attack. Lee, is there anything you would like to add?
No, I mean, I agree with everything you said. I think one thing we see a lot in our patients are like stable angina, where, like you said, there's a partial blockage in the artery, and then as you stress yourself going upstairs or whatever you're doing, the blood isn't getting enough. The heart's not getting enough blood flow, so that's when you start feeling that chest pain. Usually that gets better with rest, and one alarm sign is if your if your stable angina no longer gets better with rest or it's not going away, that would be something that you need to call 911. Um,
Okay.
yeah,
Thank you.
that Judith said that she's been diagnosed with heart failure and AFib, but has never had a heart attack. And I will say that most of the heart failure that we do see now is what we call ischemic heart failure, where it's coronary disease. The heart's not getting enough blood flow. Um, but we still see a lot of, like, probably 30% of our patients will have a heart attack and won't have any symptoms at all, or have these what we call small kind of silent heart attacks where parts of the heart are dying without any symptoms very slowly over time. That can cause heart failure from coronary disease.
Thank you. And yeah, thank you for the audience is starting to submit your live questions. We will get to all of them at the end of our submitted, but moving along here, I will go to the next question talking about heart murmurs. Dr. West, if someone has a heart murmur, is it serious and what are the next steps?
So a heart murmur is usually just a sound that your primary care physician or cardiologist has heard. It's normally an extra beat or an extra sound or a regular sound that they've heard. And it's very vague. And it's not necessarily serious or even abnormal, especially in younger patients or children that can be completely normal. If it's something that your primary care physician thinks is abnormal for your age or it's new, if your primary care has been seeing you for a while and then it pops up, that could be a red flag. And they'll normally want to look at the heart, which is usually done with an echo. And that's just an ultrasound of the heart that shows us the valves and how the function is, and it can better assess whatever sound that they're hearing.
Okay. All right. Thank you. And along those same lines, Dr. Toluca, can you discuss irregular heartbeats just a little bit more? When should someone be concerned? If you have any other thoughts there.
Irregular heartbeats?
Mhm.
I think that generally, if you feel what we would call palpitations, which is where you feel like a skip beat or rapid beats, and it's something that occurs frequently and it doesn't go away, it is a good idea to at least identify what it is. There are many different things it could be. It could be something benign, meaning like not very serious, like what we call PACs or premature atrial contractions or PVCs, and they can happen after eating or they can happen with stress. But it could also be atrial fibrillation or other. So I think if it happens frequently and it bothers you, you should certainly seek care.
Okay. That's helpful. Thank you. And talking about seeking care, Dr. West, is there a general age range that you would recommend when someone should visit a cardiologist?
No, I think the determination to be a cardiologist is made by your primary care physician, and based on risk factors of high blood pressure or if you have any heart. Um, Most of the time, blood pressure and more straightforward cardiovascular issues are treated by a primary care physician, but if they think it escalated to a cardiologist, they'll.
Okay. All right. Thank you. Okay, talking a little bit about lifestyle here, Dr. Toluca, can you just talk about lifestyle changes that can help with a healthy heart and prevent and maybe hopefully prevent any future heart issues?
Yeah. That is a really great question because I think a lot of people feel like you need to work out a lot and be, really strict about your diet. And it's kind of, it feels overwhelming. And then we just kind of give up. And, I'm not gonna lie, I think it's hard. You work hard, you try your best, but there's very small changes that could be made that could mean a lot. Like, for example, just getting more steps in, like trying to walk. And you can do that by, parking further away and maybe taking the stairs if you're able, trying to just sort of increase your fitness overall. It doesn't mean you have to go work out an hour at the gym every day. So it's small things like that, small changes over time that can lead to just more steps, right? Like the more walking you do, the better. You don't have to run. You don't have to run marathons. I mean, 30 minutes a day of walking is better than no walking. Um, Avoiding sugar, like sort of processed sugars, I think are very inflammatory, can lead to diabetes, can lead to coronary artery disease. It's definitely something to avoid. Um, Interestingly enough, a lot of people I still feel don't realize how damaging smoking is. Vaping. It it's it is a huge risk factor for heart disease and definitely something that can be prevented. Secondary smoking counts, secondhand smoking. And that sometimes it's not something that can be prevented, but it is very important to try to avoid it. I think as far as sort of nutrition, in addition to sugars, I think there are a lot of like, oh, you can't eat eggs because they have cholesterol, or I can't eat fats, but in general, moderation, avoiding highly processed foods, high in salt foods, again, just making smart choices, reading nutrition labels, and just one small change at a time.
Okay. Yeah. One small change. I think that's people can do that. So
People
thank
can
you.
do that.
All right. Dr. West, we will turn to you now. When is cardiac ablation a recommended treatment for AFib, and what about CLIP?
So we'll break this down into two parts. So ablation is basically it can be done by the cardiologist through catheters or done by us surgically. But for cardiac ablation, from a cardiology standpoint, it's normally done for AFib when you're having symptoms from your AFib, or your medicines that you're taking for your AFib are not working, or you can't tolerate them. And then they'll go in with catheters through a vein or an artery somewhere and run them up to your heart and ablate areas of your atrium that's causing these irregular beats. They basically fry that area of the heart, it scars down, and it can no longer conduct electricity. And that decreases the pathways for these irregular beats. For a surgical ablation, when we are in the operating room operating on the heart for another reason, our indication is normally we have gotten pretty aggressive about treating AFib while we're there. Meaning, if we're operating under coronary disease or operating on a valve and you have AFib, we're in the neighborhood, and it's a good time for us to ablate aberrant pathways or the routes that the electrical activity can go that causes AFib. So if we're there, we're getting more and more aggressive as a whole as cardiac surgeons, especially at Jefferson, about treating the AFib while we're there. But there's also standalone surgical procedures that we perform just for AFib, meaning we aren't doing any other surgery except for AFib, which is normally done for permanent AFib that's been treated with medicines. That's actually also been treated with ablations by the cardiologist, still persisting. And then for the clip, it is our clip is a device that sits on the outside of your left atrial appendage, which is actually have a part right here. I don't know if you guys can see this, but
Yeah.
the left atrial appendage it's on the top of the left atrium, and it's where the majority of clot comes from AFib. So one of the risks for AFib is to have strokes, and since the left atrium is not beating as well as it should, blood pulls up in there and it forms clots. And most of it, 95% of strokes from AFib, come from your left atrial appendage. So if a patient has AFib, we can very quickly, in a matter of seconds, while we have the chest open, take the left atrial appendage kind of out of the equation. We put a small clip on it, and it can no longer send blood clots to your brain or other places in your body. The indications for that for us right now are anyone that has AFib. We have really good data that shows if we clip them while we're operating on a different part of the heart, it will decrease their stroke risk. And currently, there's some trials going on that are looking at people that don't have AFib if we should be flipping everyone's appendage. So we'll have that answer soon. But definitely right now, if you have AFib and you're getting heart surgery, uh, your left atrial appendage probably be clipped. You,
Okay.
anything I missed there?
No, I mean, I think that's all very accurate. You know, the clip is just another it addresses the left atrial appendage surgically. It's not always possible because there are anatomical challenges. I mean, it's from a percutaneous standpoint or something that the electrophysiologists can do. So like they'll do the ablation through the veins and they can also put something called a Watchman device. But it during surgery, I mean, during cardiac surgery, like Dr. West said, I mean, we do perform these ablations and it can be either freezing or burning, but regardless, the end result is performing what we call lesions um, to block the impulses and to complete the treatment, taking that left atrial appendage out of the equation is recommended. And some people staple it off, some people put a clip on, some people cut it off and oversew it. I mean, there are sort of multiple ways to address it. But it's definitely something we focus on during AFib surgery.
Okay. All right. Thank you. Very helpful, very informative. So we appreciate it. Okay. Moving along, we just have a few more questions until we get to the live questions from the audience. So just a final reminder to feel free to add any questions to the chat. This next question, though, is for you, Dr. Toluca, talking about recovery. So when should someone expect, or what should someone expect from recovery from heart surgery?
So we look at recovery from heart surgery probably in three phases. There's the sort of initial in-hospital recovery. So you come in, you have your heart surgery. For most patients, the expected stay in the hospital is about 5 days. Day of surgery was 4 days, give or take. Some people are overachievers and go home early. Some people stay a couple extra days depending on the circumstances. But at the end of the day, that's a sort of an average length of stay. The majority of patients go home. Some patients need to go to rehab. And the way we sort of determine that is how they do during this, what we call acute phase. So physical therapy starts working with you once a day, twice a day, depending on, overall condition. And the expectation at discharge is that you're able to do what we call all of your ADLs or activities of daily living. So going to the bathroom independently, going up and down stairs if there are stairs in your house, making a breakfast, like sort of normal things, like so that you do not need someone there to care for you or 24-hour supervision. If you can't do that, then maybe we recommend short-term rehab, meaning you go to rehab until you get stronger and get independent to the point of, going home. Then there's sort of that middle phase where there's bone healing. If you had what we call a sternotomy, which is the most common way we approach heart surgery, just through the chest. So that bone needs to heal, and there are a few restrictions, and that probably heals at about 6 to 8 weeks. To be super conservative, you can say 12 weeks. You can maybe start doing some push-ups, but I would say not before then. And then there's the cardiac rehab portion. So you've gone through the acute phase, you're home, you've gone through sort of that intermediate phase where you're getting stronger, you're walking, you're, getting more energy. And then to really reap the benefits of heart surgery, or any, sort of heart intervention for that matter, we recommend what's called phase 3, and that's cardiac rehab. So that is a sort of, I tell my patients, it's kind of like a monitored gym. You go, they check your blood pressure, your heart rate, get you on a treadmill, get you on a bike, get you lifting some weights, sort of trying to increase the endurance, sync everything back up, and fully get the benefit.
Okay. All right. Thank you. Okay, we will move along here to our next question. Changing paths a little, Dr. West, can you discuss mitral valve leakage? And could you also discuss treatment options for non-rheumatic mitral valve insufficiency?
Sure. So mitral valve leakage or insufficiency or regurgitation are basically when your mitral valve is leaking blood backwards. So the mitral valve sits between your left atrium and your left ventricle. And normally the blood should be squeezed out of your left ventricle through your aorta to your head and the rest of your body. But when you have a leaky mitral valve or you have mitral valve insufficiency, that valve is not coming together properly and blood's going back into your left atrium and probably backing up into the lungs. The non-rheumatic part of that just means it's not related to rheumatic fever, which in the United States we don't see as much anymore, which is due to we can appropriately treat strep throat now, which is what causes rheumatic fever. So now that we're treating strep throat with antibiotics, we no longer see a lot of rheumatic disease, which affect the valves. So the leaky mitral valves we see now are usually related to valves have too much tissue, or the rest of the left ventricle has dilated out from heart failure and the valve can't come together. So when the valve has too much tissue, which is something we see commonly, one of the leaflets will prolapse and it won't come together when it should be coming to like this. Kind of comes together like one kind of rides higher than the other, and then that blood will go backwards, which can often be fixed with a repair where we put a ring around the mitral valve to cinch it up a little bit, and then we have some techniques to deal with the redundant tissue, or we can put cords actually to that tissue and tighten it down a little bit. If the problem is with the left ventricle kind of ballooning out and the whole valve is stretched, it's normally dealt with a replacement where we put an actual or mechanical valve in that situation inside the where the previous valve was. And then another option we have for mitral regurgitation for patients that aren't candidates for open surgery, and Dr. Toluca can talk a little bit more about this because they do this at Einstein. Her team does it. We now have a clip, which is a minimally invasive technique that we can go in through the groin, and you can imagine these two leaflets that aren't coming together properly. We can now put a clip in between them that cinches them together and prevents leakage. So, Dr. Toluca, what else? Since you're the
Thanks, Lee. Yeah, that was good. I mean, I think mitral regurgitation is definitely could be a very serious condition, and it has to be monitored closely, as there are certainly a lot of deleterious effects if left untreated. Heart failure being one of them. It could also be a secondary to heart failure. AFib is another sort of secondary problem of untreated mitral regurgitation. So it is something that shouldn't be ignored. Like, Dr. West said, we have really good low risk surgical options for mitral valve disease. I mean, mitral valve repair is probably an incredibly low risk procedure, something like between 0.5 and 1% mortality risk. And so it's very well tolerated. And for patients that are good candidates, that is definitely the option. For what we call secondary or functional mitral regurgitation, like Dr. West said, like the ventricle dilates, you have heart failure from other reasons, and maybe your heart isn't pumping very well, but this valve is leaking and, causing worse options. Like an endovascular or percutaneous, meaning it's a catheter-based repair, and we go from the vein, is a good option. And we have started, there's a New England Journal article that came out maybe a couple months ago and saying that we can even treat valves that are leaking moderate amount, meaning if 0 is normal and 4 is severe, even patients that have like a 3 or 3+ leakage due to what we call functional or secondary regurgitation benefit from treatment. So I think it's important that patients who have this disease are evaluated by a heart team to make the right decision, and the right treatment.
Okay. All right. Thank you both. All right. Our final question here before we turn. Oh, sorry. Do you have anything you'd like to add?
No, I would just say the other thing about a lot of these valve diseases is the structural issue with the actual heart. And there's no medicine or pills or drugs that we can give that can fix the structural issue other than surgical intervention or now these catheter-based clips. other things that change the actual function of the heart.
Okay. All right. Thank you. Okay. Last question here before we turn to live questions from the audience. Dr. Toluca, this one is for you. At what size of an aorta dilation is surgery recommended, and what are the risks of a mildly dilated aortic root and ascending aorta?
Also, excellent question. Something we field a lot. So I would say, in general, and this is in general, right? Like there are sort of specific conditions like so very specific connective tissue disorder where the sizes are a little bit different. But for the general population, I would say we consider an aorta of 4.5 centimeters a true aneurysm. Anything below that, like somewhere between 4 and 4.5, is more considered a dilation or an ectasia. So not something to really worry about too much, but at 4.5, I think we really start paying attention. And that's when the majority of our colleagues, our cardiologists, send the patients to us for surveillance, and then we put them on our, aortic sort of follow-up list. And it's important to take a good family history and make sure that, there aren't sort of sudden deaths in the family, that there are other, relatives, first-degree relatives that have had heart surgery for bicuspid valves or aneurysms or, any actual connective tissue disorders. Sometimes we do offer genetic testing and genetic counseling. So there are sort of, and it depends on the screening, right? So 4.5 is where we consider an aneurysm. And then we look at behavior. So for example, the natural history of an aneurysm is that untreated, it grows about 1 millimeter per year. And that means, high blood pressure, you're not taking your meds. Treated, it should technically, hold steady. If there is growth, meaning like we see 5 millimeters of growth in a year, if it reaches 5.5 centimeters, or if the patient starts having symptoms such as chest pain radiating to the back, chest pressure, pain, discomfort going up the jaw. There are other sort of more subtle symptoms like hoarseness or chronic cough, which can come with enlarging aneurysms. Then we would consider intervention sooner. If there is an associated valve problem, so as part of a initial evaluation of an aneurysm, we also do an echocardiogram and make sure there isn't a related valve stenosis or regurgitation, meaning that the aortic valve is not tight or leaking, and see if there is anything abnormal about it. If there are valve abnormalities, then we sort of intervene sooner, somewhere between 4.5 and 5, depending on what the valve looks like. So I would say in general, 4.5 is where we start paying attention, and then the pathways go from there.
Okay. All right. Thank you. And Dr. West, anything you'd like to add before we turn to our live questions?
No.
Okay. All right. Well, with that, let's go into our questions from the audience. How this will work, I will go ahead and read a question, and whoever wants to chime in, feel free. So it definitely can be a live discussion. All right. So our first question here, what is cardiac rehab, and what results can a patient expect from attending a cardiac rehab program?
I feel like we sort of maybe answered that a little bit earlier about cardiac rehab, and the frequency is about 2 to 3 times a week. Duration depends on what the patient's starting with. But I think the overall benefit is just increased endurance and putting it all together and really getting that full sort of cardiovascular fitness back online.
Okay. Great. All right, next question here. I know that we've received a few, so thank you all for submitting. What is a cardiac calcium scan, and is it a valuable tool for determining coronary health?
Calcium CT scan is a bunch of X-rays that they put together. You run through a scanner, and it looks at how much calcium is in your aorta and then your coronary arteries. It gives you a score, which can be a good screening tool and give us lot of data on your risk factors for coronary disease. It at this point doesn't tell us a lot about the percentage of blockages and your actual risk for heart attack at that point. So it kind of, your calcium score is high, it usually triggers either stress tests or you go have a cath where cardiologists will inject dye into your coronary arteries and look a little bit more closely at your coronary arteries. But when we get blockages in our coronary arteries, over time, those blockages are plaque, start out as cholesterol, and then they'll get calcium in them, and then calcium shows up on these.
Okay. All right. Dr. Tuluka, anything you'd like to add?
No, I mean, I think Dr. West, pretty much covered it. I mean, I would say should be used with caution, because again, just like with sort of other tests, it has to be properly interpreted. I mean, I don't know that everybody should have a calcium, scan. Like there should be risk factors, there's sort of age cutoffs, and because sometimes you start scanning and you start finding things and then you don't know what to do with it, and then you may undergo procedures that you don't necessarily need. So, proceed with caution, but definitely it is valuable in the right hands.
Okay. All right. Thank you. Okay. Next question here. Can the doctors explain what the convergent procedure for AFib is and what should a patient expect if they have this procedure?
You want me to take this one? I can take this one. So the convergent procedure is what we call a hybrid procedure. It is part surgical and part percutaneous, like through the vein. So it is a surgeon and an electrophysiologist. And it is another way of ensuring that adequate scar tissue is created to block electrical impulses from the pulmonary veins, which is where the majority of AFib usually comes from. So that is just one of the ways that we address AFib. And as far as expectations, I mean, hopefully it works. I mean, obviously there are complications like with anything. You could have pericardial effusion. It might take some time. It really takes about 3 months to say if a procedure was successful as far as restoring sinus rhythm. So it's not necessarily like, it doesn't mean that if you had the procedure done and you're still in AFib, it doesn't mean that it didn't work. It just means that it takes time. Scar tissue, some of it forms immediately and some of it takes some time. And then there's a little bit of a recovery to it, and probably cardiac rehab is recommended as well. Like I said, for all cardiac procedures, even if it was just a stent, we certainly recommend cardiac rehab to get the full benefits.
Okay. All right. Thank you. Okay. Next question here. Please forgive my mispronunciation, but we'll see how this goes. How common is Lamble's excrescence? What treatment options are available for this condition?
So Lamble's are rare string-like filaments that come off your aortic valve. And I would say they're very rare. I would less than 1% of the population. But Dr. Tuluka might have better data on their actual prevalence. It's a rare condition. When we find them incidentally, we are usually at if we're in the operating room, we can deal with them while we're there. But if we just find them and we're not operating, we need some sort of symptoms to trigger us to go to the OR. And that's sometimes they can cause strokes, or they can have thrombus on the actual string off the aortic valve. So if the patient's symptomatic from them, it will drive us to for surgery. But most of the time, we will just leave them alone unless we're in the operating room.
Yeah, it's definitely not common. And just because you have them doesn't mean you're going to have a stroke. And I think there's no indication. I mean, I would say the risks probably outweigh the benefits to just surgically remove them. I think like Dr. West said, if there is a stroke, usually the protocol is for the patient to get started on what we call antiplatelet agents or anticoagulation or both. If there is a recurrent stroke and there is presence of Lamble's excrescences, then there is a still not what we call a class 1 indication for surgery. You have to sort of assess the whole patient and make sure that still that the risk of surgery is adequate. So, but yes, not something to worry about too much, I should say.
Very rare that they need.
Okay. All right. Thank you. Okay, next question here. It's a little bit more of a specific one. This person says, if I've had heart surgery in the past, will it impact any other procedures that I may have in the future, specifically like treatments for a long-term lung infection?
I think I saw this question pop up. This was a PIC line. Someone was needing antibiotics after some sort of heart surgery. If you're pretty far out from your heart surgery and you're needing long-term antibiotics, there's some sort of PIC line or something like that. It should not affect your heart surgery, your previous bypass.
Okay. Anything you'd like to add, Dr. Toluca?
No, I mean, I think with bypass surgery, there's probably, less of a concern. I mean, there, if there is bacteria in the bloodstream, it could affect your heart valves. So if you've had heart valve surgery, that's definitely concerning, but it can also affect native heart valves. So, but it sounds like there's adequate treatment, but that is the only way, like the only sort of concern that we have when there's bacteria in the bloodstream.
All right. Okay, next question here. Are there any herbal medicines that are beneficial to strengthen the heart? And are there any herbal or natural medicines that a heart patient should avoid?
I'm gonna answer the second question because the first one is difficult to answer. But just as a general rule, I can tell you that I tell all my patients to stop all supplements about 10 days to 2 weeks prior to heart surgery because there are a lot of supplements out there that can that thin the blood. That is one of the way they work. And we like I asked like all sort of fat soluble vitamins. There are a lot of supplements, including high consumption of green tea, can cause bleeding during heart surgery. So as a rule, we always ask about supplements, basically anything you're taking that isn't prescribed by a physician, and we ask people to stop them with enough time, lead time.
All right, thank you. Okay, next question here is an interesting one. This person wants to know, what are the newest advancements in cardiac surgery? How minimally invasive are procedures now compared to 10 years ago? And what can we potentially expect in the next decade?
That's a great question. We already touched on one of the advancements earlier, which is the mitral clip. It's a minimally invasive clip for patients that have the leaky mitral valves that we talked about. In the last 10 years, a device that's called TAVR has revolutionized aortic valve surgery in our older patient population that aren't fit for aortic valve surgery. And I think we are continuing to advance the field in minimally invasive ways, which Dr. Toluca can talk about a little bit better than I can. She actually performed minimally invasive bypass surgery, which is probably rare. I would say probably less than 5% of the country is coronary surgery right now. So, well, Dr. Toluca take this.
Yeah, no, I think like the percutaneous valve therapy, like TAVR and mitral clip, and there's tricuspid therapies, which we also offer, and there's sort of more coming down the pike. So, the next 10 years, we'll see even more innovation in the what we call percutaneous space. Now, we always have to be careful because not everyone's a candidate. So I think that's why it's important, like as new technology emerges, sometimes surgery is still the best option or, the only option. Um, and minimally invasive surgery, which I guess we sort of call small incision surgery, right? So at the end of the day, heart surgery is still heart surgery, meaning we go on the heart lung machine, we stop the heart, and we do what we got to do. Whether we do it through the middle of the chest or through a small incision in between the ribs, the surgery is the same. Is just, maybe the recovery is a little bit faster, is less AFib, less, atrial fibrillation, less blood transfusions. But at 3 months, there's probably a pretty equivalent outcome. Um, the true sort of minimally invasive is to do the percutaneous procedures. And I can speak to that just because I do the percutaneous procedures, the minimally invasive procedures, and the fully open procedures. So like I've seen it, I've seen the whole spectrum. And I'm always very careful when I talk to patients about minimally invasive surgery to explain that surgery is still surgery. Like you still get sort of all those aspects of it. But if we're able to do it through a smaller incision and go for a faster recovery, we're certainly game.
Okay. Yeah, definitely important considerations to keep in mind. So thank you.
I'm gonna sort of circle back one more thing.
Yes.
I think other advances that we have made probably in the last, definitely in the last 20 years, but more so in the last 10 years is understanding post-op and like sort of pre-op prep and post-op recovery. So I think, there are patients that maybe like their parents or, had surgery sort of in the, 80s or even early 90s. And, people would stay on the breathing tube for a day, 2 days. They would be on bed rest. They would be in the hospital for a longer time. I think now we sort of understand that getting getting the breathing tube out early, like getting patients moving, avoiding pneumonia, avoiding clots, it's just all part of that sort of rehab process, understanding sort of the cardiac rehab at the end. I think those are all, in a way, advancements in cardiac surgery because they affect their recovery, they speed it up, and they get patients healthier sooner.
Okay. All right. Thank you. Okay. Next question here. We have a few more before I have one final question to close out this evening, but a few more audience questions here. This person is wondering, are there any non-surgical options available for AFib?
Sure. I think so. The first line treatment for AFib are medications to either get you back into sinus or to slow your heart rate to minimize your symptoms. And the other thing that's often recommended would be anticoagulation to reduce stroke risk. So those are the first steps that your cardiologist will normally make. Symptomatic, you can't tolerate your medicine, and start exploring ablation options, which are normally done through catheters and do not require surgery. And then the last line would be, like Dr. Lucas spoke about earlier, would be a convergent procedure or something that's done.
All right. Thank you. Okay. Last question here. A few questions tied into one. This person is wondering, I've been told I may need heart valve surgery in the future. What should I be looking for in a heart surgery program? What about a heart surgeon? What questions should I ask? And finally, how should I go about requesting a second opinion? And I can repeat questions if needed.
That is a very good question because obviously I feel like for us as physicians, part of a program, we're kind of like, well, it's routine, right? It's like it's our daily, we do, 2 procedures a day, 5 days a week. So it's sort of, routine. But for the patient, that's their first, their only, they may have no experience, and people are scared because the reality is cardiac surgery sounds scary. And I think our job as physicians, correct me if I'm wrong, Lee, is to put people at ease and really explain, like debunk the myths and explain sort of really what the expectations are. And, that's why I think this webinar was so important because we really got a chance to sort of showcase that heart surgery is quite safe if the planning, is proper. I think the first thing is comfort. right? I mean, you have to sort of connect with your physician. I mean, if you feel comfortable and you have a good rapport and you feel like you're going to get good care, it's important. I know there are a lot of people who talk about, well, how many of these do you do? And, like volume, right? So volume could be important. But what does that really mean? Like how much volume is enough, right? So I think we also have what are called STS sort of star ratings. Like there are sort of publicly available data on most heart programs that you can look up on the internet, and you can look up your physician, you can look up your hospital, you can see sort of what their track record is. So that is another way of looking at it. You're always entitled to a second opinion, and you could ask your cardiologist who to go to, or you could look online. We're always available for a second opinion. um, but I think the most important thing is, making sure that there is sort of a heart team evaluation, that there is good collaboration between the cardiologists and the cardiac surgeons, that there's an understanding of the disease process, that there's good explanation of what's going to happen. And comfort.
All right. Thank you. Anything you'd like to add, Dr. West?
I agree exactly what Dr. Toby said. I think the first thing is your cardiologist, only person that refer you to your surgeon. And so if you trust your cardiologist, they probably trust the surgeon that they referred you to. And then what you should look for, you should find somebody that you're comfortable with. It's a big relationship, having a heart surgery, and you need to be comfortable with your surgeon. And then to echo what Dr. Lucas said, every surgeon should be comfortable with their patients getting a second opinion. So you can just tell your surgeon that hey, I'm gonna talk to somebody else or meet with somebody else. They should be very comfortable with that. If they're not, I mean, that in itself should be a red flag. But talk to your cardiologist, and obviously talk to the surgeon. Just make sure you're comfortable with them.
Yeah, absolutely. Be your own best self advocate. So great. Okay. Well, for our final question this evening, I would love to ask you what your goals are for everyone listening in on this webinar. So what would you like our viewers to take away from tonight? And Dr. Toluca, we'll go ahead and start with you.
Thank you, Sarah. I think takeaway points would be don't ignore things that seem abnormal. Like, your body. And if you're not breathing well, if you've got chest pain, if you've got chest pressure, if you're noticing that your endurance is going down and nothing else has really changed, sort of listen to your body and seek care. And I think, murmurs are potentially important and they should be followed up. Taking care of yourself a little bit at a time. Like I said, little changes, just little changes. It does not have to be overwhelming. It could go a long way. You should be able to, ask questions. We're certainly available. And I think while a lot of things seem overwhelming and scary, hopefully we did a good job of breaking things down, making it seem sort of a little bit more approachable and friendly, and understanding that what we do is generally backed up by evidence, by experience, and it's not the same approach for everyone.
Absolutely. Okay. Well, thank you. And Dr. West, any final remarks?
I just want to steal what Dr. Toluca said again, and I agree wholeheartedly about the small steps for your health. If you try to change too much at once, you won't stick with it, and there are very small things you can do every day. There's walk a little bit more that can help your shit. And I appreciate patients that ask questions and that prioritize their health. I think anybody that's coming to this webinar obviously prioritize their health, which we appreciate. Having an interest in your own health, because it's so important. Your labs and your interest in your cholesterol, these little things make a difference. And the other thing, like Dr. Toluca said, is just we hopefully we can kind of demystify some of the heart surgery. And a lot of the people in this webinar are having surgery or have had surgery, but we've come a long way with the recovery, pain control aspect of it. We get people moving, we get them off the ventilator very quickly. People are out of the hospital a lot quicker, and their recovery is a lot quicker. And we've become a lot safer at heart surgery, as a whole, as a community. Gotten most of these procedures very routine. It's obviously a big deal for every patient. For us, it's something that's very routine. It's something that we do very safely.
Okay. All right. Well, thank you. And yes, just to echo you, Dr. West, thank you so much to the audience for submitting such great questions, and being your own best self-advocate. So thank you once again, Dr. Toluca and Dr. West, for your time this evening. Such great information was shared, and I know I learned a ton myself. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment. You can stay up to date on upcoming events and webinars, just like this one and more. You can also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to hearing loss, men's and women's health topics, and much more. A recording of this event will also be sent to you so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.